morning, guys. Let's talk about emergency contraception. So if a lady comes to you, patient comes to you asking that you prescribe her some form of emergency contraception, what do you do as a doctor? So how do you approach that? The principles, you have to have a clear understanding of the principles of emergency contraception. First question that will be going through your mind is, does this lady require emergency contraception or not? And then how do you arrive at that question? So you ask yourself, is she on regular contraception? Then if the answer to that is yes, if she's on regular contraception, the next question would be, has she missed her pill? Okay, so you need to define clearly whether she's missed her pill or not. Okay, or contraceptive patch. Has she missed her pill or not? If she's not on regular contraception, then the next question would be, when did she have unprotected sexual intercourse in relation to her expected ovulation date or her predicted ovulation date? So those are the two ways to approach it. If she's on regular contraception, has she missed her pill? Yes or no? If she hasn't missed her pill, then you encourage her to continue taking her pills, do the STI checks, questions and all that. Encourage healthy lifestyle, healthy sexual activities and things like that. You can always signpost her for her to go to the sexual health clinic and get further investigations if you think she might be at risk of STIs and things like that. Or you could do the swabs yourself, take some swabs, counsel her. So in terms of missed pill, you have to establish if she's on regular contraception, is she on missed pill, yes or no? How do you define missed pill? If she's on a POP, which is a progesterone only pill, okay, like disogestrel. If it's disogestrel, if she has delayed taking her pill, her disogestrel, by more than 12 hours, which means 24 plus 12 is what? 36. So more than 36 hours from her previous pill. So she took it 24 hours ago. Her next one should be in 24 hours, because you take the pill once every day. So if you take the pill on a Monday at 8 a.m, you should take the next one at 8 a.m. roughly on a Tuesday, so 24 hours later. If you don't take it at that 8 a.m. and the delay exceeds 12 hours, it then becomes a missed pill. That's for disogestrel. If it's for other progesterone only pills, then that is 3 hours. So if you're supposed to take it 24 hours from the last one and you delay by more than 3 hours, which means more than 27 hours from your last pill, then that is a missed pill. So the first thing you want to establish is, has there been a missed pill? And if you now find that yes, there has been a missed pill, then the next question you ask yourself is, does she need emergency contraception? The fact you've missed a pill does not automatically mean you need emergency contraception. But that's the first thing you need to establish, has there been a missed pill or not? If it's a combined hormonal contraceptive pill, usually it's more than 24 hours. If it's more than 24 hours from the last one, it's already missed. Okay? If it's more than 48 hours, obviously you've missed 2 pills. So your chances of failed contraception gets higher with the more you miss pills. The higher the number of pills you miss, the higher your chance of a failed contraception. Essentially, the higher the chance of you falling pregnant or becoming pregnant, which is what failed contraception means. Okay? So if a lady has missed her progesterone only pill, the next question you ask yourself is, has she had unprotected sexual intercourse within the period of missed pill? or within 48 hours of resumption of her progesterone only contraception. Because remember, for the POPs, you need extra contraception such as barrier or abstinence within the first 48 hours of starting your POP. So, which means you're not covered, you're not protected within the first 4. So even if she missed it, so she has missed it by, if it's regular POP, by maybe more than 3 hours or whatever it is, from that, within that period of missed pill, which is within the period of no coverage, no contraceptive coverage, if she had unprotected sexual intercourse within that period, then you have to give her an emergency contraception, which could be Ella1, which is olipristal acetate. You could give levonorgestrel, or you could use the copper IUCD, depending, IUD, depending on the duration. Is it less than 72 hours? Is it less than 120 hours? That 72 hours, I think, is now being defined as less than 96 hours. I think I saw a guideline that used less than 96 hours, and says with less than 96 hours you can give levonorgestrel. Okay, when I was in medical school, I think just of recent, it used to be 72 hours, 3 days. I'm not really sure if that has changed to 96 hours now, which is 4 days. If it's combined hormonal contraception, it's a little bit more complex in terms of defining whether she still has active contraceptive or contraception coverage or not. If she had her 7 pills within the first 7 days, you combine hormonal contraception, you take it 3 days on, 1 day off, either 1 day off completely or 1 day of placebo, okay, which is still off hormonal contraception. And then you start again, 3 days on contraception, 1 day off, which is the pill-free period, or the break. Okay, so that's the break. So for combined hormonal contraception, it's a little bit more complex. If she judiciously, diligently, adequately, properly took her combined hormonal contraception the first 1 week, so for the first 7 days, and she's missed 1 pill in the second week, as long as you're confident that she took the previous ones judiciously, she's missed 1 pill, you encourage her to continue, take the missed pill as soon as she remembers, take her next pill when it's due, so which means she might actually be taking 2 pills within 24 hours. So take if she remembered, oh, I missed my pill, gosh, and it's already like 6 p.m. She should take it immediately at 6 p.m. If she was meant to take the next one at maybe 8 p.m. so she's gonna take the other one at 8 p.m. She's gonna take 2 pills within 2 hours. That's what it means. You know what it means? Yeah. So I'm making it too long. Let me simplify it. So yeah, let's jump into the other one. If the woman is not on regular contraception, so she's had, first of all, you check, has she had unprotected sexual intercourse? Very likely that's why she wants emergency contraception, because she's had an unprotected sexual intercourse and at risk of, or she fears that she's at risk of becoming pregnant. And you have to know her cycle, establish what her cycle usually is. Does she know when she ovulates? If she's sure that she knows when she ovulates, then if it was unprotected sexual intercourse within 5 days, was it within 5 days of her predicted ovulation date? If it's within, that's 5 days or less within her, 5 days or less from her predicted ovulation date. If that sexual intercourse falls within that interval, that time frame, then it's advised that you should prescribe her emergency contraception to cover her. Okay, and then the unprotected sexual intercourse, you now check, okay, was it within 96 hours, or was it less than 96 hours, or less than 120, or less than 120 hours? And that will determine what exactly you should be giving her in terms of efficacy. Because Ella1 and levonorgestrel, how they work is they prevent ovulation. If this lady has ovulated already, let's assume she ovulated 24 hours ago, as she ovulated 48 hours ago, and 24 hours ago she had unprotected sexual intercourse. So she's already ovulated before she had the sex, right? What it means is that you're using levonorgestrel to block her ovulation doesn't make sense. Using Ella1 to block her ovulation doesn't really make sense, right? And that's why the emergency contraception or contraceptive with the highest efficacy in terms of preventing pregnancy remains the copper IUD. Because what the copper IUD is going to do, it's not going to prevent ovulation, but if ovulation and fertilization have already taken place, it's going to block implantation. It will block implantation. In addition to blocking implantation, it's going to it could be spermicidal as well. So the sperm cells that are swimming through the endometrial cavity, the womb, will be killed. Yeah, they will be killed. So the sperm cells will be killed. That's the spermicidal effect of copper as well, the copper IUD. Okay, so it's just an overview. It can be quite complex, but it's good to understand. If you understand the principles, if you understand why you're doing it, and if you know, it's like mathematics, show all workings. You know, everything starts from one point and gradually, moves. So it graduates. Okay, you have to know your starting point. You need to know how you're going to move. So I'm starting at this point. You need to know the first principles to consider. The second principle, the third principle. That will help you actually simplify the concept of emergency contraception. Because in all honesty, it can really be complicated sometimes. So I've just got to work, and I'll have to say I hope this driving video has been really helpful in terms of simplifying the concepts of emergency contraception prescription. Okay, deciding. The first question is you have to decide whether or not this lady actually needs emergency contraception. Okay, does the benefit of prescribing outweigh any potential risk? Lovely. Have a great day, guys.